Hello, and welcome to the Longev Lens. Please join my co-host, Dr. Sebastian Pedersen, and I as we cut through the noise and hype around longevity, health, and wellness, and turn the latest evidence into honest, practical insight for living better for longer.
And just a quick disclaimer before we dive in, this podcast is for educational purposes only and doesn't constitute medical advice. If you have a healthcare problem, please consult your doctor or qualified healthcare professional.
Welcome back to the Longev Lens, where we cut through the noise and hype of medical and health issues with the most updated research as best as we possibly can. Today, I'm joined again by Dr. Sebastian Pedersen, and we've also got our very first guest, which we're super excited about, is Dr. Vu Tran.
Thanks for coming, Vu.
Thanks for having me.
I'll just give you a bit of an intro for all the listeners. So, and this is just what I know about yourself. So, GP, founder of a unicorn $3 billion valuation company. You're founder of One MRI, bloody good tests. You're now building rockets, and there's so many other things I don't know about you. You're very unique, have seen a lot of things in the world, and I do think that the way you think about health, the way you think about how the health system operates is very valuable for us, but also to our listeners. So I'm just very privileged that you came on board today.
Thank you so much for having me, guys. It's a privilege to be your first guest. It's very cool. I didn't even know that.
You certainly are. So I think obviously the big priorities of today is talking about whole body MRIs.
Yep.
Because you've been co-founder of One MRI. So I guess initially just wanted to go over what is it, what are the pros, what are the cons, when will we do it, what the current approaches within the standard medical system thinks about whole body MRIs, and where there's a bit of conflict, where there's a bit of grey area, and then we can sort of get into the details.
Yeah, look, as I mentioned before, thanks for having me on, guys, and any opportunity to be able to kind of talk about an area that I'm incredibly passionate about, which is healthcare, I always jump at, right? In my world, my background as a general practitioner. I saw my patients last night in general practice, but where I spend my time day to day is in the innovation space as a startup founder and in the technology space. So my big part of it around One MRI, and I guess the reason for focusing on full body MRIs is multifaceted. As I mentioned before, I still practice as a general practitioner. I've had the same patients for over 10 years now. Where I did my training as a registrar is actually where I still see my same patients today. So I've got some families who I treat where I've told the couple they're pregnant and now they're having their second or third child, right? So being a doctor and being a family doctor is a real privilege. And for me, the opportunity to, I practice in a really working class area in Logan. I've got great patients, and it's the opportunity to really be at the coalface, to be able to see what is happening in the world. And I'm very privileged. I work in the startup space, and as founders, as you guys know, we kind of work in a little bit of a bubble sometimes. But in general practice, it's my happy space. It's a space where I get to connect and really look and see what's happening right at the ground level in the world. And one thing I really love about healthcare is it's the opposite to make a difference, the opportunity to make a difference, right? And I always think about how do we make a difference at scale, and one of the greatest things about growing up in the times and doing the things at times we're at now is the opportunity to leverage technology to make a difference at scale. And so being at that sort of intersection of both technology and healthcare is really exciting for me. And if I look at whole body MRI, if I can bring it back to you on first principles before we talk about the scan itself, I've been really fascinated to think about the role technology is playing and could play in healthcare. And when I think about healthcare, I think about all the different parts of, say, of medicine. And the most technological enabled part of all of medicine for me is radiology. Now I'm a general practitioner, I'm not a radiologist. But if I break down every segment of healthcare, I go, which part of healthcare? Surgery, cardiology, gastroenterology, which part of it is the most tech-enabled part of all of healthcare? And it's radiology. Yep. You don't have electricity, you don't have technology, you don't have computers, you don't really have radiology to an extent, right? But if you think about it, and I think about my role in general practice, if you said to me, Vu, when it comes to prevention of disease, especially up until about 6 months ago before they brought in CT scanning for detecting lung cancer, the use of radiology for prevention of disease, the only two tests that I could tell you that come under Medicare at least is bone mineral density scanning for osteoporosis and mammograms for breast cancer. They're the two main preventative scans that I can think of that come off the top of my head when you ask me that. Now, if you think about that, radiology being the most tech-enabled part of all of medicine, and the only bits of prevention we're using that technology for is breast cancer, and I don't mean only. Obviously, they're really and osteoporosis.
Yeah.
And if you think about what gender do they really sort of focus on, women, and rightfully so. But that's the big gap, but also the big opportunity for me.
So much valuable insight.
Yeah,
in
well, it's just
radiology that, like, all of our jobs are determined by sometimes.
Yeah.
exactly. And I zoom out a step further for you. When it comes to, let's say testing in general, what do we call the places we go to get a blood test done? We call them pathology labs. And if you look up Medicare and you go, what do they call radiology practices? The term that is used under Medicare is diagnostic imaging services. Both those terms talk about about treating or detecting disease, pathology, diagnostic imaging. None of those terms refer to preventing disease, right?
So interesting. I've never thought of it like
Yeah.
that, but it is so reactive.
It's
Even
very
in
reactive.
that,
It's the ambulance at the bottom of the cliff, right? It's sick care over healthcare. And so zooming out for you, the concept with One MRI isn't just about doing full body MRIs. It's about how do we unleash the power of technology to actually start preventing disease. And it's almost a bit of a challenge to radiology, which is a field that I'm not in directly as a general practitioner, to be able to say, come on guys, how do we leverage all of this amazing technology that's available to us? If you look at the complexity and the physics and the science that goes into an MRI machine, you go, holy cows, we should be using this technology to prevent disease, not to just diagnose it, right? And so the foundational principle is this idea that, how do we unleash this technology for prevention, right? The other thing that it comes back to for me is the world is changing so quickly right now. I think about it going, if you're building technology that you could have built in October 2022, you're probably not leveraging the technology that was unleashed on the world from November 2022 onwards, which is ChatGPT, AI, and all the byproducts that are coming off the back of it. So for me, it's kind of this world of like, how do we bring all of this to the fore, right? And again, I'm speaking at a very high macro level at the moment, but zooming in on full body MRI itself. So I kind of want to give you an insight into the behavior of a typical GP like myself, right? So I would have patients come in and say to me, Doc, can I get a full body scan? They wouldn't say what sort of scan, a CT, an ultrasound, an MRI. They just say, I want to get a full body scan. And my instinctive reflex response as a GP for 10 years is no. Not, why do you want to get it done? What makes you ask that question? My instinctive, the reflex that goes off in my brain, and you'd probably see this in all of our colleagues,
absolutely,
would be no, right? Not why, not tell me what's worrying you, or why do you want to get it done?
Exactly.
Or, actually, I'm assuming you're worried about something, not do you want to be proactive about
that's the same
something.
with blood tests too. Like if you've got more than the standard blood test, it's everything, not just imaging.
Exactly. And so I'd have patients come and ask me these questions. My reflex was no, and I'd just be like, yeah, well, and if I think more deeply, if I reflect on it, my rationale for saying no is actually based on my own biases. And those biases come from a whole bunch of different areas. The first one being that you don't need it. And you don't need it because I'm making that decision for you, by the way. I'm making that decision for you because, one, well, I don't even know where the hell to send you to get one done, right? Two, it's expensive. And so I'm just going to assume you can't afford it or it's not worth it for you. So I'm going to make that decision for you. But the third part that it'll come back to is that my honest question is, what happens if we find something? Right? Like, and I know that's a terrible thing for
or
a
you
doctor
don't know what
to
to
say.
do with the information.
Or what to do with the information. And that for me is kind of like, holy cows, why do I want to open Pandora's box with this patient? But I'm making all these decisions on their behalf. Right? And it comes back to something that we're taught in medical school very early, which is the concept of informed consent, right? If you go to get a surgery done, if you go get a blood test done, if you get examined, we need to kind of get your consent to do that. Also let you know why and what the risks and benefits are, right? And so for me, we're also entering this sort of weird sort of collision of different things. One is around the fact that, technology is evolving at a rapid rate. But two is that consumers, I'm going to call them consumers, not patients today, if you don't mind, because I think that shifts the way that we view people.
That's why we always choose clients.
Exactly, right?
We feel like we owe more.
Exactly. Well, when I'm training registrars, I say turn them in. This sounds very sort of, people grasp their pearls when I say this. treat your patients like a customer. In other words, focus on customer service. Give them great service,
Yep.
right?
Yep.
And so when it comes back to it, I look at it and I go, well, consumers are now more educated
Yeah.
about their health, whether it be through this podcast, whether it be through doing different things, through reading, through ChatGPT, through AI, through being able to just get access to the internet. They're more educated about their health than ever before,
Yep.
or they have more opportunities to. The second part of it is they're
Does
more...
that worry you?
Well, you raise a really good question. I was asked by a colleague the other day, I was told by a colleague the other day, someone needs to do something about Facebook groups because my patients are coming to me. You know, she said to me, patients are coming to me and they trust a Facebook group more than they trust me. And I said to her, look, I mean this with all due respect. You're my friend and you're my colleague. That's not Facebook's problem. That's your problem.
Yeah.
Because you don't have the relationship and the trust with your patient to the extent that they believe a whole bunch of strangers on a Facebook group more than they trust you.
Yeah.
And, you know, with AI, and I know I keep coming back to it, but with the role that AI will play, people will point out all the flaws in AI today and what it can't do well. But if I remind you that today is the worst it'll ever be moving forward, then you should think about where that can go.
That's exactly right.
And then, so from my point of view, I think one of the biggest challenges is that as doctors, we need to learn to better learn to be enablers and trusted advisors in healthcare than to be gatekeepers.
100% agree.
You know, it's such an important part of it.
Yep.
And so bringing it all back, it was just this sort of concept for me where it's like you've got this collision of technology ramping up, coinciding with consumers being more educated about their health than ever before. And I think COVID has played a role in accelerating this, consumers being more conscious and curious about their health than before. So the question is, what are the different opportunities there to be able to bring things to the fore for them? Now, full body MRI isn't something that we've pioneered globally, right? It's been around for a very long time.
Yep.
You've got great companies like Prenuvo and Ezra in the US who have done over 100,000 scans in the US. I remember being at a dinner where, 12 people around the table had gotten 11 of the 12 people around the table had gotten a full body scan. The only one who hadn't was me, right? This was in the US. And just thinking about it of going, you know, why is it that it's just people in Silicon Valley getting this scan, right? So the third part of it for me is thinking about accessibility. And the challenge with all the technologies, like our scan is not cheap. It's just under $3,000, right? So it's ironic that I'm saying, oh, look, it's accessibility is a core focus, but it's a $3,000 scan. But like any technology, I think about electric cars. You wouldn't have an affordable BYD or whatever electric car that exists today if you didn't have the Tesla Roadster or the Tesla Model S, which was 300 grand when it came out. And so for me, it's about looking at how do we look at making it more accessible and then driving that cost down over time. And what that does is it makes it allows us to be able to really push the technology for the benefit. But again, now zooming in, just in terms of what the full body MRI is and kind of how that goes about doing. So I'm going to share a secret with you. It's not your full body. It's actually from your head to your mid-thigh is the protocol we run. So we spent about 2 years really focusing on really developing a protocol that would allow us to be able to find this balance between making sure we scan the parts of the body that will give us the most value, while also, and again, I want to define for anyone who's listening, the difference between an MRI machine and a CT scanner, just so that people are aware. The MRI machine is the tunnel, the CT scanner is the donut. And if you've ever been in an MRI machine before, you'd say, look, it's probably not the most comfortable of spaces that exist there.
Jackhammer in your ear as well.
Exactly.
It's pleasant.
And so you put on we can put on a podcast for you or some Netflix while you're watching.
Chuck
But
the long Jeff lens on
but
one.
the key part of it for me is, you know, the idea of being stuck in a machine, like the tunnel, for a long period of time is not great, right? And so for us, we have to find this practical balance between time in the machine. So it's about a 45 to 55 minute scan. So it's just under an hour versus the clinical value that we would get from it. So up front, we don't scan your knees and your ankles. Our rationale behind that is there's not too much data we can get from that that's useful. And if you've got knee problems or ankle problems, you're probably getting targeted scans of those areas anyway. Now, I'm always really upfront, and what we drive ourselves, I mentioned consent before. We really focus on the consent process in doing the scan. Now, it's not just about the risk of MRI and the fact that it's a giant magnet. If you've got a piece of metal on you, you rip through the magnet. I mean, that's just MRI safety. But it's around actually intent and sort of the risk of getting scanned, right? So the scan itself is an MRI. It doesn't have direct radiation like you would in an X-ray or a CT scanner. We also don't use contrast. So the contrast dye that you might use in some scans, we don't use because we're scanning quite a high volume of people.
Yep.
We don't want to have the risk of an allergic reaction to the scan, to
Yep.
the contrast or damage to your kidneys. So we avoid that. But the more important part that it comes back to us is that in that consent process, what we really want to do is make sure that people are doing it for the right reasons. They have a full understanding of the risks and the benefits of the scan. And most importantly for me, it's those risks, it's those downsides, you know. And if I can open up to you guys what those risks are, you know, the biggest part for me is actually not that we miss something. And we can talk about that a little bit later. The biggest downside to me is that we find something that ends up being nothing, right?
Yeah.
The term we use internally is we call them incidentalomas, which is a fancy way of finding out something incidentally that ends up being benign. And what
We've already had a few of those go through as well, which at first they might seem alarming, but then if you delve in a little bit deeper, then it's actually, it may just be normal.
exactly, and but it's a really big downside, right? And I always load up front the downsides because again, it's about informed consent. And the downside is, Seb, we scan you and we find a spot on your liver, and that spot on your liver really causes you massive anxiety because you're sitting there going, "Whoa, what is it? Is it cancer? Is it something scary? What's going on there?" And we say, well, we can't tell you because the follow-up is to go through with your doctor or with your treating physician to be able to get follow-up scans. And you might even go all the way down the rabbit hole. And it might take weeks to get to the point where they even put a needle into your liver. You know, I'm being extreme here. And they get a biopsy of it only to find out it was benign. And so we've put Seb through all of that stress only to find out it was nothing. Because we opened Pandora's box by doing that scan. And that for me is something that I'm and my team are really, really aware of, but we're really upfront of. But again, I go back to that sort of my role in general practice where I was making decisions on behalf of the patient and going, actually, no, we should actually be letting the consumer
Decide.
make that decision, but be educated enough about it.
But I think those, at least from my personal experience now with using whole body MRIs, I do find, so they're direct-to-consumer tests. They're private. People are paying for them. So I do find that if there is an incidental finding, most of them aren't always nothing. They just require follow-up every 6, 12, 18 months just to see if there's any progression or changes. But the turnaround time for ruling it out is very quick.
100%.
Because we see people, clients who've had them, because they're all private, we would call the radiology practice that we use directly back, hey, can we get a diagnostic imaging of this area of the body tomorrow or the day after? So it's like 24, 48 hours, and then we know what it is.
100%.
Rather than waiting weeks and months of anxiety. So I do find that as long as we inform them straight away and action it, and then us rule out or rule in what it could be, I find that reduces a lot of anxiety.
100%. And I think the really interesting part for me is that it also forms a baseline, which is quite valuable. Like, you know, one of the things that I want to be able to do is go to, you know, defense as an example and say, I'd love to be able to do a full body scan on everyone who joins the army on the first day. And then on the last day when they leave and be able to compare that baseline for you, right? Like that for me is an example, right? Where the ability to get this general picture and overview and baseline that over a period of time.
What's pre-existing.
What's pre-existing.
Exactly right.
And you know, that's from an occupational point of view. But if we think about that from a general health point of view, how many times, you know, in your previous medical career where you've kind of scanned someone, you've looked at it and you go, that's probably normal for you,
exactly
right? But we don't know for sure. And what I think is interesting, and where I get a lot of criticism from fellow doctors, even mostly fellow GPs, will say like, you know, are you dealing with a worried well, right? And I'd say to you that actually a majority of our consumers, of our users, are actually the opposite. They're actually the curious well, right? They're the ones who actually go, I'm actually not worried about my health. I actually want to be able to live longer,
exactly
and I'm
right.
doing this proactively. And that's a really difficult sort of headspace for us as doctors to be in because we're used to treating sick people. So the idea that perfectly well people, like just, you know,
I hate that, isn't it? Doctors are only seeing sick people.
Well,
like,
but if I
it's so true.
reframe it,
It's so true.
If I go to, I would be willing to say to you that 99.9% of doctors out there
100%.
are used to seeing someone who has a problem. Right?
Yeah.
Literally, when we say,
It's so true.
Corey's
So
coming
true.
to see us,
Yeah.
we go, literally the first thing we ask
What's the problem?
technically is what's
Yeah.
the presenting
Yeah,
complaint?
that's exactly right.
What is the presenting complaint?
Yeah.
What is your
Yeah,
problem,
yeah,
right?
Yeah.
So that's what we're
Yeah,
taught at
well,
medical
it's
school.
so true.
right?
It's so true, and we could do so much better of changing how people approach their own health from a younger age, rather than just waiting for them to see a doctor when an issue arises.
But it's ingrained to us as doctors from medical school. Our job is to solve problems,
yeah.
not prevent disease, right?
That's exactly right.
It's framed. I like to sort of describe it to people that in general practice for me, and if you think back to when you were in the emergency department, for general practice for me, I don't know if you remember this show from the 2000s called Thank God You're Here,
Yeah,
right?
of course. Yeah.
That's what general practice is. You open that door and you don't know what's going to come in, right? It could be anything on the spectrum of a prescription, right, through to someone having a really bad sort of, mental health or drug addiction issue, or through to cancer. The spectrum is so broad.
Yeah.
And so, we've got this sort of thing ingrained into us as practitioners of dealing with people's problems. No one ever comes to a GP, unfortunately, and says, "Hey, doc, I'm here to say hello and see how you're going and just to tell you I'm having a great day." Right?
That'd be refreshing.
They're here, rightfully so. They're here to, if pain persists, what do? See your doctor, right? So I do want to say to you that there is a systemic sort of challenge that we run into where not just consumers, but the system itself, but more importantly, the doctors and the clinicians who work in a system. We're in this profession because we want to help people. And often the way we frame helping people is to solve their problems.
Yep.
I would say that less than 1% of doctors, the majority of their work is focused on trying to prevent disease. A lot of it is focused on trying to deal with problems and disease or some sort of issues. And that's where, for me, I've got if I can zoom out even further for you, I'm involved in healthcare at a state level, and I'm part of a team that looks after an entire health service. And when we look at a health service that I'm involved in, we oversee 20,000 staff, 1.2 million people on the south side of Brisbane, and we have, we spend about $4 billion a year on health on the south side of Brisbane where I'm from. And, someone says, look, that health service should be spending more money on prevention. I turn to you, Seb, and I go, where do you want me to take it out of? Do you want me to take it out of the emergency department, pediatrics? The budgets are finite in terms of what you can spend on health. The big challenge is that, depending on what study you look at, for every dollar we put towards prevention, we're probably going to get about between $10 to $14 back. Now, the problem is, who are we going to take it off to do that investment? As much as that makes sense, do we take that money out of the emergency department? Right? And the answer is no, because you can just imagine what the flow through effect is. Which is why another principle in terms of looking at what we're doing with One MRI is that the consumer being at the center of healthcare is super important. Because I think in order to truly prevent chronic disease, it's not going to be about an awareness campaign or investment from the government. It's going to be about a cultural shift for the consumer. And if you follow the bouncing ball, for me, it's like, if you're curious about your health, you're more likely to do something about your health, prevent chronic disease, live longer, live better lives, all those sorts of things.
Reduce
so that's
hospital admissions, reduce...
Exactly right. And so for me, it's about feeding that curiosity. A lot of people will look at One MRI and go, are you screening for cancer? And I'd say, we pick up... we picked up a cancer the other day in a consumer, which was out of left field for me, but it reinforced why we do what we do. And when I looked at it, I go, well, actually, part of it is actually feeding people's curiosity. Have you ever seen what your brain looks like? Have you ever seen what your liver looks like? Right? And walking a consumer through our report and showing them a picture of their body in a way they've never seen before. It's a really cool thing to do, because what is more intimate than seeing literally the inner workings of your body, right? And the other thing I'd say to you, and this is not me flogging a scan to you, but I also challenge you to tell me, what other tests can you do that gives you a snapshot of how your brain, your spine, your liver, and your testicles, right, are going all at the same time, right? And that's the thing for me is, you know, where full body MRI might take us, I don't know. But it's this idea of being able to really push the area of radiology to a point of thinking
Yep.
about the profession differently, or
Yep.
thinking about technology differently.
I think
What is something that you see at an individual level in clinic every day that you'd like a larger audience to know more about?
Oh, I mean, from a general practice perspective or from a One MRI perspective?
Yeah, or disease management or, yeah.
Oh, look, I think that the biggest thing that I would love anyone who's listening to sort of really, really think about is this idea, and it's a bit of an odd concept, but given your background, Seb, you know, in particularly your experience with geriatrics and those sorts of things, I think it's really important, and getting a bit philosophical. The human body's evolved over 200 to 300,000 years, right? We weren't made to live for more than 30 years to 40 years. So when the body gets to the age of 60 or 70, it's sitting there looking at its bucket of DNA and goes, hang on, I don't have a few 100,000 years of instructions on what to do here. Does that make sense, right? And the reason why I bring that up is because we're trying to help the body adapt to aging in a way that is not natural to the way the body has evolved. I know it's a bit of a tangential, like an abstract thing to say, but just think about it, right? 500 years ago, we're not meant to live to 60. And so how much, so for 295,400 and whatever, 90, you know, and 400 years, the human body's we get to whatever age, and that's as long as I need to evolve for. And in the last 100 years, we're like, nah, we're going for 80 and above, right? And so as a result of that, from a DNA perspective, our body's looking at going, I don't have enough clubs in the bag to be able to know how to play this shot, right? And so the role of like what you guys are doing and the work that you're doing, and the conversations you're having, and looking at new innovations and new technologies and new ways to think about things, is trying to supplement that. I see that there's a delta there. I know it's a really abstract thing for me to bring up, but you know, because people come to me with problems, you know, I had one of my long-term patients come to me, and he's 80 and he's a good 80, right? And he's saying to me, yeah, but I just can't do what I used to do. I say, yeah, but mate, you weren't meant to live this long, right? And I've known him forever, so it's odd for your GP to say, yeah, but you're not meant to live this long. But in the grand schemes of 300,000 years of human evolution, we weren't meant to live this long.
Exactly.
And so the ability to live better and longer lives is not going to come down to the human body's ability to adapt, but our ability to use science and technology to really adapt to it. And the reason why I bring that up in terms of what would I love consumers and patients and users to know is to go, bridging that gap, we can't rely on our bodies to do it. We've got to rely on the innovation, the technology, the science that is in front of us to be able to bridge that gap, because the human body is not going to evolve in the next 30 years, but technology will.
I think even just knowing that from an educational perspective is good to know as well. It literally is, as you say, only the last 100 years that people have gone from like a life expectancy of maybe 50 to 60 to now on average in our Western cultures like 85. That's a huge,
that's exactly right.
Huge gap in a very short period of time in the grand scheme of 300,000 years. To then go, okay, now we need to figure out everything we can possibly do to try to make sure that it's not just trying to live a long life, but actually living a really healthy, you're sharp, you're physically capable.
Well, I put it to you this way, right? And this is going to sound, you know, I want this to come across the right way, but you look at Rupert Murdoch and you look at Warren Buffett, those guys are in their 90s, mid-90s and beyond. And they look strong, both cognitively and physically. You look at those guys and you go, I want whatever they're having, right? And I look at it and I go, it is possible to live longer, better, sharper lives. But a big chunk of me just says we just can't rely on the human body to do that naturally. Anyone who lives naturally to 100 and is super cognitive and super, you know, fit and healthy and all those sorts of things, they're an outlier. And they're an outlier because probably of genetics. But, you know, they're no different to, I don't know, a mutant. They're Wolverine,
Mm.
right? The question is, what is the opportunity to bridge that gap to be able to bring the average punter up to that stage?
Exactly.
Right.
I think before I want to dive into some more actionable stuff, I think 3 things that I want to pick up, and I just love listening to you because it's refreshing for me to hear colleagues, because I find innovation within the medical sector
Yep.
is super difficult, especially if it's clinic facing or consumer facing, as you mentioned, because it's a little bit of the tall poppy syndrome. A little bit, if you're doing something different compared to the norm, you get scrutinized, or you mentioned it. There's the inherent biases that people judge you without knowing that what you're doing is not right. What are you X, Y, Z? Like, are you doing something with more risks versus benefit? But I think innovation is something that I love what you're doing. One thing that you said earlier is the cost.
Yes.
Now you mentioned $3,000, which is less than $75 a week.
Yep.
Really. If that's a make it or break it situation for people to invest a little bit into their health, considering everything else they're investing, whether it be holidays to mortgages to car repayments to everything else, and if you don't have your health, you don't really have anything else. So for me, I think that change, and it's happened with healthcare. Sorry, it's happened with education. People know that if they invest in education, they will get return on investment. And the same thing is going to be happening with healthcare.
Yep.
At that price tag, yes, of course, the imaging is just one element, and then there's the physical assessments, the pathology, and et cetera. But I do find that people do need to start investing in their health. Otherwise, as you said, you're going to get to 60, 70, and then there's just going to be a sharp decline.
And valuing it.
Yeah,
Right.
that's exactly right. But I think that understanding of not expecting the system to help you or to solve your problems, like if you want to live well, you have to take control. You have to take steps now, so you don't become a statistic where, over 50% now of people over the age of 60 in Australia have at least one chronic disease, most likely 2, which is crazy.
Yeah.
And I just find that people do need to invest in their health.
If you don't mind, one of the things you mentioned before was around that sort of criticism from colleagues and peers in the profession. And what I'm going to say is I do think that criticism is fair, right? And the reason why I think it's fair is, as a general practitioner, you won't ever see me experiment in general practice. So the example I'd give you is that if a new drug was come out, and let's say it's the best drug possible for heart failure, right? I would not be using it. I'd want to see a cardiologist that I'm familiar with and to prescribe it 50 times with 50 patients before I prescribe it. And the reason being is because as general practitioners, we're the top of the funnel. We deal with more of the average population than, say, for example, the subspecialty a cardiologist might. And so for me, if I'm experimenting at the top of the funnel, there is a greater risk of amplifying any adverse outcomes or whatever it may be. So for me, it is actually appropriate that my colleagues and I are actually quite conservative when it comes to what we do in general practice, right? It's an inherent built-in feature rather than a bug, is the way I look at it. So I really empathize with my colleagues who are critical and go, but I'm not expecting general practitioners to start referring full body scans for their patients. I don't expect that at all. In fact, I don't think that's likely. It's not just not the way that we're rolling. And so when I get criticism from, say, general practitioners around it, I actually say it's fair because I don't expect you to be referring. The Royal Australian and New Zealand College of Radiologists, RANSCO, actually very much say that there is no evidence the quote is, there is not yet enough evidence for the usage of full body MRI in screening at a population level. And I think that is 100% fair statement. And I'll tell you why. There's probably, I'll break it down to 2 things. One is they're 100% right. There is not enough evidence yet, right? Because it's an emerging field. And I fully agree with that. It doesn't necessarily stop early adopters who understand the risks of the benefits of it to be having a go and using it and seeing what that does, right? The second, as long as we can manage that risk. The second part that it really comes back down to is that when we talk about population level, it is also some of the downsides of doing this at significant scale from a cost perspective, both directly and indirectly. And thirdly, is the system's just not geared to do it, right? Like we've got over 40 clinics across Australia now that do our full body scans. And we're the largest by coverage easily in the country. Well, actually coverage and volume. But I can guarantee you if it was kind of made readily available through Medicare or whatever else it may be, the system wouldn't be able to cope with it. So I'm just acknowledging that both a GP's position of, hey, it doesn't make sense to be doing this from a general practice perspective, definitely makes sense. And from the Royal Australian and New Zealand College of Radiologists to say there's not yet enough evidence to be able to do screening using this as screening at a population level, I also think that's an appropriate position to take.
Correct.
Again, thinking about the top of the funnel. And so I'm actually not supportive, but understanding of that position. I don't ever expect to see this on Medicare, right?
Yeah, correct.
I don't, right? And in fact, I do think that in some cases, if it were to be Medicare rebatable, it would actually decrease the value that people would put on it in terms of being proactive about it and whatnot. So that's a completely different kettle of fish. But what I would come back to is that I definitely understand where those positions sit. What I find really ironic, and I'll share this with you, and this is an insight as to how sometimes we think as doctors, is when I first started talking to my good friends from university, they one's an O&G, the other one's a cardiologist, and I went and had breakfast with them when I was visiting them in Sydney, and I said, look, I'm thinking about this full body MRI concept. You can imagine what the answer was. They both said to me, no, you can't do it. It's irresponsible. All the different things that they would say.
What is that knee-jerk reaction within the field?
It's the same thing that I said to you in terms of a doctor of going, no, cost, access, where do you even start?
So you've assumed before anything else.
But the irony of it is they're like, no, you can't do it. Doesn't and they both said, yeah, but when you do set it up, can we be the first people to get scanned? I turned around and I literally said to them, I said, dudes, how is it that on one hand you're saying this shouldn't be done, on the other hand you're saying that you want to do it? And the reason why they said is, but we understand the risks.
Like you said before, people are becoming much more educated now. There's so much more access to information.
I called them out on the spot, and these are my two closest friends, so I get to, with your mates, you can just rag on them. And I just said to them, so you're just saying because you're a doctor and you think you're smarter than the average punter that the risks, so therefore you can go get the scan done. But there's no way in hell that we could inform the average consumer enough that they can understand the risks and benefits and make that decision for themselves. And I really called them out on that, which case they obviously had no answer because there was a hypocrisy there. But I guess I point that out in that there's this sort of unconscious bias and sort of, I wouldn't call it trauma, but bias that we carry with ourselves as doctors where I believe that all of us are in this profession altruistically.
Correct.
And so we're doing it with good intent. But that good intent sometimes also creates this boulder, this roadblock that gets in the way. That again, the fact that in medical school, we are taught to talk about the consumer or the patient's presenting complaint. What is their problem? Not exactly. What is the opportunity?
Exactly. I think statistics-wise, do you have some of the, because I obviously have my own statistics that I use and I educate people. What statistics do you use in terms of what proportion of people have a finding, what proportion of those people have a significant life-changing finding?
So again, we're very early on in our journey. So we've been publicly scanning for only 1.5 years now. So when they say there's not enough evidence, I fully agree with that early on. But I can tell you with the scans that we're doing at the moment, about one in 4, we will find an incidentaloma. So I'll start with the downside. I always start with the downsides, right? So one thing you'll learn about me is I want you to know about the downsides first before I talk to you about the upsides or the potential opportunities. And the biggest downside for me is in around about 1 in 4 to 1 in 5 people will scan. We'll find something that ends up needing more investigation. Most of the time, that ends up being nothing, right? So that's the first part. And that for us, at with a subset of under a few thousand scans, is actually quite consistent with the data of the overseas guys who do about 100,000 scans, right? It's about 25% for us, 30% for them. And with the numbers we're doing at the moment, we're seeing just under 4%, about 3.5%. So let's call it 1 in 3. 3 in 100 people having significant findings, right? And again, that's consistent. This is one thing I find amazing about statistics and medicine, where you then can look at sort of larger data sets and you go, holy cows,
different countries, very similar statistics.
And and so for us, those sort of roughly 3 in 100, so 3%. So we've got to scan 100 people to find something life-changing pretty much. Those people are asymptomatic. They don't have, again, I had this example of a user from a few weeks ago where they had no symptoms. They were part of the curious well. And she ended up having a large cavitating lung lesion.
Yeah, wow.
But she was asymptomatic. And that was wild for
Yeah.
me because I was like, do you have any shortness of breath? Do you have any symptoms of cough? And she's like, nope. And the way that we found out about how her treatment went and whatnot after that, because her partner then came in to get scanned. And he told us the story of what had happened and all these things. And that for me was kind of the eye-opener. And I always bring this back to the team, is going, on the average person that we're engaging with, we're feeding their curiosity about their healthcare and we're giving them insight into their bodies. And for that very select few, for that 3 in 100, we are potentially bringing about sort of life-changing findings
That's exactly right.
to the positive. Because I could say to you that this person would not have found this for a number of years.
Correct.
And they weren't a smoker, right? It's not like they worked with, like, in mines or in bench, like, in synthetic stone or any of that sort of stuff. It was like the last person you would expect.
Plus you found it in sort of the area of the body that the MRI is probably the worst at finding something.
100, like, and sorry, I should have probably pointed that out at the start. Things MRI, full body MRI is terrible at. That I also lead up front, right? So I should have probably given you that example at the start, actually. So there's two things that we will always point out to consumers as the most important parts. One is the risk of finding incidentalomas, but the second is what is an MRI not great for, right? And for me, there's actually a few areas. So even though we scan the lungs it's actually really bad for not really bad for. It is nowhere near as good for as CT scans, as an example. We can see lungs because they're like a giant sponge in a different level of detail on a CT scan that we would on an MRI. The heart itself, and I think the reason why I bring up the heart is because the heart's really important. I'm sure you educate your consumers around this, but the heart is a dynamic study you want to get. You want to understand how the heart's functioning and pumping. And so getting an image where we're getting you to sort of hold your breath and sit still of the heart is not great. So we get a snapshot of the heart, but it doesn't tell us about how it's functioning. So the heart and the lungs they're not the gold standard for the heart and lungs. And probably the most important area is the bowel that it's not great for. And, to share with your audience, the reason why is I'm a GP, so I'm really simple. I have to always try to explain things to patients in a way that I would understand, which is the simplest way. And I always think about the bowel as like a giant set of tubes. And if we can get a picture of a cross-section of a tube, that's okay. But what we want to know is what's going on the wall of the tubes. And that's why in a lot of circumstances, the gold standard is a colonoscopy. So we can get a camera up there, look around and see what's on the walls. And if there is a bit of an early cancer there, it is much easier to see with a camera looking at the inside of the tube than it is doing a scan. Those are kind of the three main areas. And the breasts, even though MRI is great for the breasts, if it's targeted, because we're doing a general scan, we do a scan of the breast, but we don't do it the same way that you'd have a targeted MRI of the breast you would do. So those are kind of the areas that I really call out. It's not to say we don't scan them. We scan them. But is it the gold standard? No. And I guess the last thing I'll touch on is that radiology, despite it being the most tech-enabled part of all of medicine, it still is reported today by a highly trained doctor who sits in a dark room looking at the picture and telling you what they can see. Now our bet is in the next 5 to 10 years that will change.
Correct.
And we'll be able to use all the advances in AI to sort of enhance and complement that skill set. But today, it's still Bob sitting in a room staring at a screen and scrolling through an image and saying what they can or can't see, which means that because Bob is a human, there's always the risk for human error. But Bob is still the gold standard. Sorry, Bob is the name I give an radiologist, right? Just to de-identify our team members. But it's super important to also be upfront with consumers about that. The system is imperfect because we use humans. And as humans, we are imperfect.
No, I think in terms of how do I implement it in our practice, for example, when do I use the whole body MRIs? Whole body MRIs are a tool in the toolkit. It's not everything. But you mentioned earlier that radiology, there's not a lot of screening available for radiology. So often when we have clients come in and we do a lot of genetic testing up front as well to see if there's any genetic predispositions, but also family history. So if someone's got a family history of solid organ cancers, whether it be brain, liver, pancreas, always scares me.
Yes.
And there's no screening available at all.
Yep.
So what would have happened is they may have had 1 or 2 first-degree relatives with the same cancer.
Yep.
If we didn't have scans like whole-body MRIs, like targeted MRIs, these people are very likely or at a significantly increased risk of getting these cancers. And then if they were to get it, because they always present late, it would have been too late to do anything about it.
Pancreatic tail lesions are the scary ones, right? Where we look at that and we go, you know, Steve Jobs, right? Like you've got someone like Steve Jobs who, and again, put aside all the stuff he went to once he found out he had cancer.
That's exactly right.
But you look at it and you go, it was one of those things that you can't pick up until it's quite late, as Seb's pointing out. And your 5-year survival once you're diagnosed, because you're picking up so late, is quite low compared to everything else.
And what do people say if you get that cancer?
Well,
they would say bad luck.
And I think this is the big part is we, as clinicians, we correlate history, which is symptomology, and data, right? So we can look at your family history and go, okay, what's your risk factors? But then we also look for symptomology, right?
Yep.
And I love the fact that you look at genetics, right? Because again, that is unleashing a whole bunch of technology that didn't exist 5 years ago, let alone 15 years ago, let alone 25 years ago. And it's about just trying to put that at the forefront of, because what I'm really excited about is also on the other end, which is the ability to then use genetics from a treatment point of view.
Exactly right.
Because you come in to see me as a GP today, I'll give you the exact same medication that I'll give a 16-year-old girl for, say, antibiotic treatment or antidepressant treatment or whatever it might be, as I would give a 70-year-old 150-kilogram male. Right? Like, it's just, we treat very, very, it's not even empirically. It's just what's in my tool bag to be able to treat with.
Exactly right.
The ability over time to tailor treatment to the individual or tailor management to the individual.
Correct.
Super exciting world.
Oh, absolutely.
But you need to understand the individual to be able to do that.
It's exactly like we use a lot of genomics when we need it.
Hugely.
One thing that frustrated me when I used to work in the hospital system was clopidogrel.
Yep.
Like the 30% resistance rate of clopidogrel.
Yep.
But everyone after a stroke gets put on it, hoping that's going to work for them.
Hail Mary.
And it's just like, for me, and the good thing is now, and that I still know people here within Gold Coast Health who are now doing research articles on this to show that, the rehab physicians are, that people are coming to them with stroke and they need to do this, at least get funding to do this genetic test to see will they respond to this medication and will it actually reduce the risk of having subsequent strokes.
100%.
Like, this is great, but this is how long down the track? You know what I mean? Like, it's just a matter of the whole red tape of funding, of getting the approval. The data's there. The evidence is clear. It's frustrating when, exactly as you said, we get into this role to help people, to give people the best possible outcomes, and then sometimes we can't offer what we want to offer or provide the care we want to provide, just because either there's no funding or there's other barriers, I guess.
Well, and what I would say is that, and this is not a criticism of the healthcare system that I'm involved in at both state and primary care level, but universal healthcare is there to provide a safety net and a floor, right? It's from where we should start from. It shouldn't be our expectation of what the standard should be. I know that's a bit of an odd thing to say, but the care you receive in general practice or in hospital, whatever it might be, it's there to capture, to make sure everyone's got something there. It's insurance, right? Yep. But it shouldn't be the bar to be able to say this is the best you can be,
exactly
right?
Exactly
and I think that's super important. And that's why I think that delta of going, this is the best you could be health-wise, and this is where the health system can get you, that delta needs to be bridged by the consumer because the system can only go so far, right? And I think of, if we think about, it's this idea of, this is a bit odd. I have a cousin who was very much into crypto, right? And he would say, he used to send me this meme of whenever there was a coin that was going down, people would send this meme going, devs do something, right? And I think to myself sometimes when people see problems with healthcare, they go, government do something, right? And it's kind of like, no, consumers.
Yeah, that's exactly right.
As long as there's people like yourselves and like us who are there to provide opportunities and options to consumers.
Educate.
There is this big part where it's kind of like, how do consumers take more responsibility for their health as well? Because that ultimately is going to be what, again, as I said, prevents disease, reduces chronic disease, ultimately allows us to live longer, more fulfilling lives, right?
Exactly.
Yeah, which is, I think, needs to have more onus on the actual person and
Yep.
not relying on
External sources.
the medical or allied
Yeah.
health professions as much. It
Definitely.
really needs to be taken responsibility of.
Mm.
Is there, if we come back to the MRIs, we haven't touched on the benefits quite as in depth yet. Is there any things that you'd really want to be touching on with the whole body MRIs from a beneficial perspective?
Yeah, I think I've touched on them briefly, but I think what we're finding with the consumers and the experience they're having is I always, and again, I always thought it was going to be, we find stuff, they're grateful for it, and we don't find stuff, they're relieved. And there's that middle ground around education and insight. And we find that it's a foundation for a whole bunch of different things. Like I said, that feeding curiosity. So I wouldn't necessarily add anything more, but I'll expand on it for you. That ability to look at your spine and understand whether your spine's in good nick or not as a 51-year-old really does sort of impact sort of what you need to do moving forward to an extent. So
It gives you more direction.
it gives you more direction, right? Like it's kind of, we're all involved and run businesses, and the more data we have, the more informed decisions we can make. And one of the sort of unintentional learnings or byproducts we've had from doing these scans is really realizing that consumers use it as an additional data point, not the only data point, but as an additional data point for them to be informed as to where they're going to spend their time, effort, and energy. So I think of it no different to a CEO who's going, give me more insight so I can make more informed decisions. And it was kind of one of those things that kind of wasn't necessarily on the list of benefits that we'd look at. It's hard to describe to consumers. I can describe it in a conversation with you guys, but you can't really put it in a pamphlet, right? But it is one of those things where it's been a really interesting byproduct. Again, it drives that curiosity or feeds that curiosity. And I think it's hard to be able to kind of capture this, but the amount of empowerment that comes off the back of it is quite significant.
That's important.
Both in terms of the negative findings, in terms of not finding anything, but also in terms of the positive findings, in terms of, I use the spine as a really good one. Like people won't scan the spine unless they've got a problem. Isn't that interesting? But that's probably an area where there is quite a bit of degeneration over time.
I do find it's probably the area that probably requires the most education because the words so big in the report and they look very bad. Even though it's exactly as you said, just age-related changes.
And I think, my thing that I find myself talking to consumers about often is I go out to Woolworths right now. I go out to Woolies right now because the practice that I'm in has a Woolworths outside. I say, Seb, I go out to Woolies right now and I grab 40 other people just like you and I find the same stuff in a whole bunch of them, right? And that's my way of not necessarily saying, hey, you've got a 1 in 6 chance or 1 in 8 chance, whatever it is. It's just to say this is part of being a human, right? Like I had a guy who was a bricklayer. And he had a really bad really bad shoulder, right? And I said to him, well, mate, you're 62 now. He's still working at 62 laying bricks. I said, how many bricks have you laid in your life? And we did the calculation on the computer. It was like several 100 million bricks or something stupid like that. And I said to him, like, cool. Can you tell me a machine that does this 300 million times and won't need a joint replaced, won't need something done, right? And he said, yeah, okay, fair point, right? Like, it's also helping people understand that they are human, right? And I use this analogy all the time also with patients and consumers, and I say, it shouldn't be surprising that the last 100 meters of a marathon is a lot harder than the first 100 meters because you've just ran 42 kilometers in between. And that just contextualizes it for them, is that the human body is an organic, but even machines, like is an organic machine, but even actual machines made out of steel and composites, they wear down. And so for us, it's about trying to, again, use technology, innovation, insight, and data to think about how do we prolong, fix, or improve a big chunk of it.
Exactly.
Like, our heart is the most amazing machine in human existence, right? If you think about it, what else makes that many movements consistently
That's exactly right.
for up to 100 years and doesn't run into any problems?
I think that's a perfect spot to wrap it up. There's a lot of really good information in there about whole body MRI, about the GP practice, about your perspectives of where you guys are trying to think. Because again, like you sort of say, like a lot of people have a perception around doctors now that they feel like they know more. Whereas you've also got some other things going on in the back of your mind about where we actually fit into the system and how this can actually work. So thank you again. As I said, your first cab off the rank really in our guest. And yeah, it was awesome. Thank you for having me on board.
Guys, thank you so much for having me, and it's a privilege to be here. Thank you.
Thank you.
Thank you.